To the N3C Community Forum, and as always, we're recording and put up your hand, and if you could, very good, okay. And as you probably got a feeling, Peter Leese will be talking about CMS use cases. Well, you got a feeling that Peter Leese would be talking. I suppose he wouldn't really have a way of anticipating the topic, but that should be very, very interesting. Okay, we're seeking feedback, still seeking feedback. Short survey, click on the link, please. That'd be very useful. Next slide, please. Pretty much the same stats as before. I'm not actually sure if they're precisely the same stats as before, but they look pretty close from my recollection. 8.5 COVID positive cases. Next slide, please. So this is the last talk presentation before the holidays, and our own Chris Shute will be talking about tenant model updates January 8th, and that's been an area of a lot of activity and interest for a lot of us. And then TBD, followed by AI functionalities on the Enclave. Kate Bradwell, Maya Chodari, and Saad Lizoli. Next slide. Okay, so I think Peter, it's all yours. So if you could share your slides. So Peter's going to talk about CMS use cases.
Sure, thank you. Let me just go ahead and share my screen. Okay, just confirming that everybody can see my screen at this point. Yes. Looks like it. Thank you. Thanks for having me. I'm going to be talking today about the CMS claims data in the N3C Enclave, a topic that some of you probably know about. It's not totally clear how much dissemination's happened. So, a big part of today, I think, is just kind of cheerleading visibility, marketing of this, in addition to kind of the educational aspect of what is claims data, what's it doing in N3C, how do we use it, how do we access it, those kinds of things. And so just to, I guess, give some context, so I direct the data science lab and the UNC Chapel Hill School of Medicine CTSA program. So the data science lab in the School of Medicine is one of the groups at UNC really heavily involved in N3C and Recover. And so my role in claims data, I'm certainly not the only person involved in claims data, but I did get asked to get involved in just reviewing aspects of it, looking at architecture, kind of making sure it was ready to go, and then doing some refinement, and then I was actually also involved in some architecture that I can talk about. So I'm certainly not the only person or the central figure in claims, but I have certainly been involved in it a lot from the N3C and Recover perspectives. So, if there's one big bullet takeaway on this, it's CMS claims data. They are available in N3C as of now. And really, there are a couple different ways or flavors that the CMS claims data come in. One is really optimized for actually doing work, doing research. These are the real CMS claims, both Medicare and Medicaid claims data from a number of sites. And the Medicare claims come in either a claims format or an OMA format. I'll talk about that a little bit later on. The Medicaid data currently only come in an OMA format. But then there is an additional set of claims data, really more if you're just interested in, maybe you've never worked with claims or you're looking to test something. There are SynPuff, synthetic Medicare claims from CMS. And I believe those are in claims and OMA format in some of the training areas of the Enclave. And those are very easy to access. There are no restrictions. They're synthetic data. So they are really just sitting out there in training areas. Obviously different use cases, but access is no obstacle to getting into those SynPuff data. some basic stats, and I guess I should also just pause and say, somewhat unfortunately, I can't actually share much specific data about the claims or actually show you some specific examples right in the claims, just because of the sensitivity of the data and sort of the sharing format here. So I have some summary stats and then I have some generalized examples, but I'm happy to try to answer questions or other things if I can. So with that said, basic stats on both the Medicare and the Medicaid claims. And both of these, it's worth pointing out, are opt-in really for the sites. So even though you participate or a site participates in the N3C EHR portion, that does not automatically mean that your CMS data comes in. The site has to opt in to bringing that data in, and then the Medicare patients from your EHR data will get matched and go through PPRL and all of the other things to bring your respective CMS data in. And so that is why, rather than 80-something sites of claims data, you can see it's 25 sites that are currently opting in and bringing data in for Medicare, smaller for Medicaid, only 11 sites currently. And if you look at the total population of patients, distinct patients available in Medicare, it's about 350,000 over all 25 sites. Again, in Medicaid, quite a bit smaller, only about 58 to 60,000 over all the sites. And then if you look at the data per site, it's a median of about 11,000 in Medicare, although that range is pretty large. I want to say it's something on the order of like, the smallest is at 1,000 patients and the largest is up to 50,000 patients or more. So quite a large range on the Medicare side. The median on Medicaid, again, much smaller, somewhere around, mid 2000s, 2,500, 2,600 Medicaid patients per site. And again, with a fairly large range, going all the way down to something very small, maybe even below 1,000, up to, a multiple of 2,500 per site. Age or the date ranges, these go back, about to the beginning of the EHR period for N3C, maybe even a little bit before for Medicare, 2017. To the most recent I've seen is 2022. I was a little surprised that I didn't see 2023 data in there, but at least from looking at what is there operationally available now that I can access, I was seeing 2022 as the most recent. Medicaid, a slightly longer time period, 2015 to 2022. But I want to pause and shift gears a little bit because I was asked as part of this, not just to talk about the claims data in N3C, but also just to maybe talk about claims data in general and try to get people that maybe have been using the EHR data, or have been involved in N3C, but have not heard of or used claims data, to just maybe try and do a little bit more visibility and education around claims data. So we're going to really shift for a portion of the slide and just talk about kind of some fundamental aspects of claims data and what they are and differences to EHR and how they get used. So in this, incredibly basic diagram, I've really got what you would think of as a single, care delivery site or health system kind of within this gray box, right? So think of this as, the UNC health system or whatever your AMC health system is. And you probably have a pretty good sense that there are all of these care delivery sites within the health system. These could be hospitals, they could be outpatient surgery clinics or ambulatory imaging, physicians' offices, all different kinds of things. And EHR data is basically getting collected or documented to document both care and to some degree operations at these sites. And all of that care and operational documentation is flowing up into some typically standardized, centralized EHR data system, right? So at UNC, this is Epic. At this point, many of our AMCs, it is Epic, although we recognize there are others out there, Cerner, Allscripts, et cetera. But the difference then is all of that is really sort of within this gray box that's sort of health system defined. claims data is extremely different in that claims data is really what leaves your health system or your health system EHR data system to go to an insurer for payment. So the claims data are really the mechanism by which health systems, hospitals, doctors' offices, standalone practices send their data to get paid by whatever insurer they need to get paid by. That could be commercial, it could be CMS. So obviously CMS is a huge insurer and nationally covers our Medicare and Medicaid, and that's who's represented here. But starting to think about some of these differences, so the EHR data is very health system dependent and focused. So when you look at, say, UNC EHR data, or even EHR data for any of our sites in N3C, you're really seeing a large amount of often detailed information, but really restricted to the confines of that single health system. And even within N3C, we don't really do any tracking to see, so take UNC and Duke, for instance, which are, geographically close, which do exchange patients. We don't really spend much time tracking or seeing if we have UNC patients going to Duke and vice versa, and trying to track, their composite healthcare across institutions for the EHR. Claims data is a completely different paradigm, though. The insurer, as the payer of any health services covered under insurance, which for most patients is really all of their healthcare, they really have 360-degree view. So here you can see in this diagram, I've added these other health sites, right? Hospital, some ambulatory offices, and data from all of these places is flowing into CMS as claims. And so when you get claims data from an insurer, you are really getting 365-degree view of health services and health actions for a patient, regardless of where it happened. And so this is a really major foundational difference between EHR data and claims data. And it really starts to drive some of the use cases for the differences between EHR data and claims data. And so this is one of the big things that you start to see when you're getting large data sets from somewhere, right? When you're getting large data sets from health systems, it's what I would think of as really site-centric data, where it's so much of the boundaries of the data set are defined by what's happening within the confines of that single site, as opposed to claims data, which I think of as much more patient-centric data. It expands the boundaries out past health systems, and it really defines kind of the operational reporting unit much more at the patient level, and you're getting everything that rolls up to a patient that's insured by that insurer. And so another really big piece that's important and really sometimes even drives use cases between EHR and claims data is standardization. So as many of us know, there's really, I would say, surprisingly little true data standardization on the EHR side. Healthcare in America is very tribal. The practices clinically don't necessarily match between one site and another. The EHR install and optimization and configuration doesn't necessarily match from one site to another, even when that's the same platform. So for instance, we know Duke's Epic install is different than UNC's Epic install. And so while there, portions of Clarity and other aspects are going to be the same and standardized the same, it's far from the amount of standardization where you could say, take data from one, union it to another, and feel like you have something that's a workable EHR data set. It's far more heterogeneous and complicated than that. And then factoring in that, obviously, as I was speaking to before, we have other large-scale systems like Cerner or Allscripts. And then at the private or community level and the ambulatory physician office level, I mean, you have dozens, if not probably hundreds of small scale kind of outpatient focused EHRs, each with their own design and system and interoperability configuration, right? So I have Athena Healthier as an example, but that's just one of a very large quiver of EHRs kind of focused on that market. And you compare that to claims data. So claims data is really fairly well standardized at the national level. And historically, before data systems were really fully kind of digitized and electronic, claims were really standardized by paper forms. And so here are two examples of these two forms which did this. The UBO4, the Uniform Billing 2004 form, really for facility claims, and what was originally the HCFA 1500, or now would be the CMS 1500, really professional claims form. But you can see that, I mean, the data is really structured and also highly limited by what fits on this sort of, single page of paper, and also what is, categorized by the boxes as defined on these. And so for whatever messiness and sort of heterogeneity lives in all of these respective EHRs, when claims are going out, they're really pretty heavily standardized into these structured units, for professional and facility claims feeds. That's really required by insurers to, get paid or to receive the data and evaluate it, and then make payment decisions back to providers. And what this really means is that, as we've sort of seen, where we're kind of at the beginning of networking and integrating multi-site EHR data and really thinking about the heterogeneity and lots of the different issues that come up with that, claims data has been much more standardized for decades. And so there's much more, I would say, routinized, standardized process and work around, what does multi-site claims data look like? How is that data structured? What are the, the structural units? What's the architecture for it? That can really simplify a lot of that work of working with claims data, just from the standardization and even the architecture for it. And so just to kind of pause and take a recap of thinking about EHR data in N3C versus claims data in N3C. So, and also to give a chance to use some of the verbiage that I think people see oftentimes associated with these topics. So, what EHR data in N3C, how would you define this type of data? I would call this a mix of both clinical and administrative data. So some data is really from sort of deep clinical systems. So I think of this as, things like lab systems where you're getting LOINCs and lab results out, but also administrative data. So we get things like ICDs and, much more terminology, operational and billing terminology sort of data sets out, as opposed to claims data, where you're really only getting administrative data. You're, by definition and by functional scope in claims data, you're really only getting things that are used to identify chargeable units or for billing purposes. So typically these are things, associated with terminologies of either ICD or HCPCS level 1 or level 2, or maybe revenue codes. And as sort of leading into the purposes, the data is really driven by the purpose. The purpose of the EHR data is really documenting clinical care and to some degree operations. And that's, in opposition to claims data, where the purpose is really to record reimbursable activities and to standardize that to send it for evaluation by an insurer or a third-party payer. And as we've talked about, the focus is care site in EHR versus much more of a patient focus in claims data. But then to maybe more think about the pros of each and the cons of each. So on the EHR side, I think it's probably not surprising. I've referenced this a couple of times. The EHR data is much clinically deeper, I would call it. And by this, I mean, there's just more representation of systems. So you might get nursing charting, you might be able to get lab systems, respiratory therapy systems, imaging systems. And additionally, you get much more detail in these systems. So you are not focused on the sort of pure narrow scrape of data required to handle billing activities. And so you can get a much deeper, more detailed data set. I think, negatives to EHR data is a steep learning curve, particularly for people that are maybe not coming from a healthcare background. I think it's no surprise that it is extremely heterogeneous and messy, and a considerable amount of time in EHR data is either figuring out what's going on and correcting it, or just even attempting to figure out what's going on. And also that often you're really working with single site. Even in sort of networked systems like N3C, we don't really have good mechanisms today of, say, following a patient potentially from one site to another site and tracking care longitudinally over health systems. That's, I would say, still fairly new, novel types of work in EHR data. And now compare that to claims data, where some of the benefits are native multi-site, so you're getting all the care for a patient. There's really pretty largely regulated data structure, which lends itself to kind of data structure and architecture. And I would also say an implicit piece of this is the confidence behind the data. Because of the billing and reimbursement process on the claims data side, there's typically a large amount of confidence that something in claims data is there with really good reason, either to get paid for something that happened or to justify something that happened, as opposed to sometimes in EHR data where it's a little bit harder to maybe suss out what the intent of a piece of data is. And that's, kind of built into claims data. Because if you're doing something wrong or you're submitting something with errors, probably the best case scenario is you won't get paid, which is, there's obviously an incentive on the health system or the provider side to get paid. And at the worst case, you can be committing Medicare or insurance fraud. And so there are pretty large incentives on the claims data side to get data right and to really have things in that I think you're confident about and confident that you're correct. I think there might be some debate on whether claims are easier to learn and understand. I guess my perspective on this is that they're so much more focused. I think there's less breadth and scope in claims data. And so to me, I think they're a little bit more approachable. But there are detriments. So obviously claims data is limited. It's very distal from the care delivery. So depending on your real project or hypothesis, claims data might not have the data or the data detail that you need to do a project. And another piece is just the typical delay in receiving claims data. EHR data can be often close to real time, especially if you're at a site and getting data from that same site. Whereas claims data, I mean, there's always a lag, and depending on the tightness of a claims pipeline and the adjudication process, it could be anywhere from a couple of weeks up to 3 or even 6 months to really have final claims data for a patient service. And so again, depending on use cases, claims data is kind of ruled out sometimes for things that are time sensitive. Okay, and so a quick lightning break before we move on, just to think about some kind of general uses of claims versus EHR, and to kind of think about this from a testing perspective. So should I generally use claims or EHR? And I included generally here because, as I find with anything in healthcare, it's really impossible to make bold statements about always or perpetually or forever. So I would say these are general rules of thumb to keep in mind, but there are always exceptions. So generally, if you're trying to identify whether a patient ever had X, right, was ever exposed to a drug, ever had this certain type of procedure, something like that, I start to think about things like that from a claims perspective, where you're really getting 100% of visibility of a patient's care services, over their covered period of time. And this is where, you have the chance to potentially lose so much data, especially for exposures and things like that when you're working with EHR data in the single site piece. And the other piece is just the confidence piece that I was referring to before. So again, generalizations, but kind of standard rule of thumb. And then kind of switching. So would you generally use claims your EHR to identify, whether this specific thing happened with a patient? So what I mean here is like, did a person, have this lab test? Like, did they have a positive HIV test? Did they, come into contact with respiratory therapy? Like pretty specific granular types of things related to the clinical care. This is where, I mean, often EHR is what you would maybe think about more rapidly or more readily, because of the proximity to the actual clinical care, and because of the breadth of systems that's really covered in EHR. So again, kind of quick rules of thumb, but certainly, not hard and fast things to adhere to. And now switching back to think about claims data in a little bit more structured way. A couple of people that I've talked to have kind of indicated that they have some experience with commercial claims, but they were a little apprehensive about looking at the CMS claims in N3C because it's so different. And so I wanted to spend a little bit of time kind of talking about this piece, the CMS piece, and talking about how we did it in N3C. So, up to this point, I've been talking about claims data as this sort of big umbrella term, but claims data is always really a multi-file or a multi-table data set, depending on what you're working with and where it's coming from. My experience is that commercial claims often come in sort of a small number of files with lots of different things jammed into the files. So, from commercial claims, I feel like it's often to get kind of a 3-file format. You have something like inpatient and outpatient and prescription, or maybe facility, professional, and prescription. But governmental or CMS claims are a very, very different format. And this is typically from whatever vendor you're working with. This could be ResDac, or it could be, from a commercial, non, research data vendor, or state level Medicaid. But governmental claims, I find, are almost always split up into some similar format to what you see here. They're split up basically into these files that define either sort of specific billing structures or kind of care delivery mechanisms. So there's typically a patient-focused file. Here, it's the MBSF, the Medicare Beneficiary Summary file. And this is where you're going to get things like beneficiary ID numbers, their coverage periods, some demographics, these types of things that are really, about patients and patient coverage. And then you get several really more clinical claims focused files. Typically, these big ones are an inpatient file, some sort of outpatient or professional file, and then a prescription file. And then over time, CMS has really started to break things out more and more and more. And so now, for instance, if you went into N3C, you would see an inpatient file, a beneficiary file, a home health file or table, a skilled nursing, outpatient, prescription drug, hospice, durable medical equipment, and a professional bill. And so, in some ways, this is handy and it facilitates working with data because, you maybe don't have to totally know how a data or how a health service is delivered and understand the billing mechanism to know how you're going to identify it. If you're interested in hospice, you kind of have this clean hospice file to work with. But it can also potentially add a little bit to some of the confusion because say you're interested in a composite of 100% of a patient's care, there's some work involved in putting this back together and sort of knitting patients across all these various care files to get into the composite view. And so, depending on a use case with CMS data, your experience can vary. But this is typically fundamentally the claims structure, or what I would call the sort of native claim structure for CMS data. And I guess the other thing that I have to say, just to do kind of due diligence for somebody that's not experienced with claims, and especially Medicare claims or CMS claims, is that claim structure really comes in two flavors. There's a header flavor and a line flavor. And this is all about the aggregation of the underlying data. Claim headers or invoices are aggregated. So typically, that means data has been brought up to be one row per patient, with things like dollar amounts summed up to a total for a total invoice level, versus claim lines, which really show all detail for a health service, really at the chargeable element level. So here you can see, in claim lines for this patient, the patient is going to be repeated over and over and over again, with the difference being typically, that there's a different CPT or HCPC, or maybe a revenue code on each of the different lines, showing the different sort of incremental costs associated with each line level element. And so, this starts to get into some nitty-gritty detail, but this is often necessary to understand when you start to look at especially CMS data, because there's oftentimes not a lot of indication at the file level what's going on. And so you kind of have to know that these two things exist to be able to kind of orient yourself. And so I need to talk a little bit about claims processing in N3C, and if you get in there, what are you actually going to see? And so we have quote unquote claims data, and that comes to really N3C as DI&H for ingestion as these claims files, structured out, broken out the way I showed into DME and inpatient and outpatient and et cetera. And then DI&H runs these through basically two different ETL processes. This is at least for Medicare. One really does some pretty basic integrity checks and cleans up those raw files to make the tables a little bit more understandable and brings them in as those discrete files, right? So if you got access and you went to, in the enclave, the Medicare claims format data catalog, you would see these files, and these have been back-checked and they have integrity down to the row level in the raw claims data. Now, the other way they come in is to actually convert all of that raw data to an OMOP format, which obviously makes it much more compatible and similar to the existing EHR data, but it also makes it very difficult to kind of back check to the raw claims data, or maybe even to try and validate something from the EHR to the claims data, because it's been sort of cut up and repartitioned into the OMOP structure, especially on potentially something like visits, where all of these sort of potentially different visits across a whole range of different files have been merged into the visits file. And so you have to think very carefully and do some investigation if you're interested in, say, counting a certain type of visit that maybe exists in a single file in the pure claims and has maybe gotten converted in a way in the OMOP format. So the question I get often is, well, okay, I have access. What should I use, the claims format or the OMOP format? And again, I think I can try to give you my perspective of some general rules of thumb, but I think, a lot of this is personal preference. So existing claims users and people that do a lot of claims research, I find tend to want to use claims in their native format, and so they tend to move towards the claim format. Others that are maybe not as experienced with claims or trying to sort of do kind of different merging of the EHR and claims together, or maybe a little bit more drawn to the OMOP. I mean, so to me, I think of it a little bit, more structurally. So depending on the data requirements of what you're trying to do, some things don't make it from the raw claims into OMOP, just because of the way OMOP works. So, structured things like revenue codes and DRGs and all of the ICD metadata, all of that does not necessarily make it from raw claims into the OMOP format claims. So that's a potential cutoff. And then another piece is, what I was talking before in terms of row level integrity and lineage for validation, right? So for instance, when I'm looking at validating, was this person that shows up as being in a really long inpatient stay, were they actually in the ICU? I prefer to look at the claims format claims, because I know that that data has integrity all the way back to the build finalized claims. And so there's been no additional adjudication or conversion of that data. And then somebody else asked me, can you just try and tell me, map Medicare components to files? And so, this sort of quick notes takeaway, right? So Medicare Part A is inpatient. Part B is really professional and a lot of outpatient. DME and, potentially other, parts of some of the files can get read through Part B. Part C, so Part C is Medicare Advantage. Those, I mean, that means your Medicare is being insured through a commercial insurer. So we have no data on Medicare Part C patients. And Medicare Part D is prescriptions. And yes, Medicare Part D is included in these claims data. And then I thought of special notes that sometimes come up and are relevant to people. So, depending on where you're looking, some medications are delivered through prescriptions, some are delivered through Medicare Part B. And so in OMA, typically all medications sort of get moved over to drug exposure. But in raw claims, obviously there's a mix between the prescription and, potentially the Medicare Part B or the professional build file. This is where there's some amount of knowledge and expertise of both the health service and the billing mechanism and then the claims mechanism to kind of parse out, where do I look for what data. And then another sort of generalized claims research note, substance abuse and behavioral health claims are almost always scrubbed from claims data, in case your use case involves one of those two. And then I'm just going to try and do maybe about 5 more minutes to leave time for questions. But I wanted to run through, again, just try to look at some generalized sort of claims examples of, okay, what would be a use case for claims data in N3C, since I can't really get in and show data and kind of walk through something. So one example that came up that I thought, oh, claims data would have been pretty helpful with this would be actually looking at kidney transplants in N3C. So on our renal tenant, we were really interested in looking at, kidney transplant procedures, which is obviously, like a big resource-intensive surgery. It seems like it should be easy, but it turns out that it's not, just because of both the heterogeneity of clinical care, and also I think the site level sort of differences in, who's sending what data and how are they converting it to OMOP. It sort of wound up, we struggled to feel like we were identifying all of the kidney transplant you'd expect from all the different sites. And so, claims data, again, where you have this significant confidence of the data, right? Like if you're going to send a claim for a kidney transplant surgery, the claim is going to be pretty clean, most likely. It's going to be well identified both on the professional and the facility side. And so, for sites that had claims data, it offered up an option or another alternative to sort of look and find patients that got renal allotransplantation in claims and figure out, do those patients also have it in these sites and the EHR data? Are there codes that we're missing, or is there sort of, data weirdness in, either the site or sort of the OMOP piece that we're missing on the OMOP EHR side. Let me skip past this slide. And then I wanted to speak briefly to ICU care because it's a similar use case. So I think many people are kind of familiar with this, but again, because of weirdness, both in sort of clinical care, but the way that's documented and the way the data sent and site level heterogeneity and mapping, I think there is not a huge amount of confidence that we really accurately identify either that a patient received ICU care in the EHR data, or the accurately identify the duration of the ICU care. But this is another really great example of ICU care is resource intensive, and so places want to get paid for this. And so ICU care is typically something that's going to be pretty clean in claims data. And so, if something's weird and requires validation or checking, looking in the claims can offer, either a good option to sort of look at a cohort, produce a cohort if it's small, or, give some insight into, places that are maybe using different codes or some data things that might be happening between sites in the EHR data. And then multi-site care. So this is something that we've talked about quite a bit. So you're interested in a patient and you're trying to figure out, like, did this patient get exposed to something, or did they ever get this procedure, or, even did they ever have COVID? Like, just because in the EHR data at a single site, they never appear to have COVID, is it possible that they showed up at some other site with COVID? Obviously, we can't really get that from the EHR data, but claims offers a solution to this. And then sort of the final piece that I'll give an example on is visits and encounters. This, unfortunately, is probably too big of something to get into very deeply with the amount of time we have left. But suffice it to say that the visits data has been extremely messy and heterogeneous in the EHR. And many of us worked on a paper, around macro visits and the high confidence hospitalization algorithm, really trying to retrofit or post hoc kind of come up with a solution to make the EHR visits data make sense. But claims are a really natural sort of foil to this again. We would have the ability to really validate or look at different types of algorithms and compare it to a gold standard of say, inpatient visits or ICU exposure in claims, and then compare that to the EHR data. So I was, very involved with this. I'm happy to talk about this more. There's just not, there's so much involved. It's hard to get into it with, without going down a bunch of rabbit holes. But let me quickly just talk about accessing claims in N3C. So as I've said before, claims are available. Medicare and Medicaid claims are available. The projects that I know that have added claims to their DUR are DI&H and the level 3 logic liaison workspace. I know Recover has not added claims to DUR. I'm not sure about other research groups in N3C. I do know that a big obstacle has been that when a project goes to add claims, it's an update to everyone's DUR. And so for something like Cover that has dozens of sites, it would mean every site really updating their DUR to include claims, which has been, I know, complicated in some of the bigger research groups. But it is available today. It is definitely being used and is available on those operational sides. I just don't have visibility on every single more research-focused group. Claims educational resources, really ResDAC is by far the best and most comprehensive. ResDAC is really the CMS's national clearinghouse for CMS research data, at the University of Minnesota. In addition to handling data requests and supporting, the getting of data, they have tons and tons of educational data and references. And then I also just want to take a moment to give visibility and thanks to the many, many, many people that have been involved in claims. As I said at the beginning, I was not involved in this alone. So Stephanie Hong and team, Chris Roeder, Brian Laraway, very, very involved in the OMOP architecture and the actual loading, ingestion, processing, and loading of the claims data. PIs, there are probably more PIs that are involved, but the ones that I worked with the most were Melissa, Emily, and Chris on this. Palantir, very involved. Sod, other people from Sod's team, like Phil Sparks and others. And then from AHRQ, we had Locke Sampson and her team really advising and consulting with us on structuring claims data optimally in Palantir's platform. So I want to give visibility to Locke and her team as well. As well as others. So obviously we worked with people from NCATS and had conversations with NCATS. Many people were involved. And I want to make sure to give visibility to that and thank everybody involved. So let me stop presenting there and come back and just take a few minutes to see if there are any questions or discussion that anybody wants me to talk about with our remaining time.
Peter, great talk. Thanks. So we have question from Benjamin Bates in the Q&A. I'm asking these questions prior to seeing CMS data in N3C. 2 questions. One, are the CMS claims and the N3C EHR partners actual dates of service? Asking in case claims and EHR dates do not align despite occurring at the same health system. Good question. And 2 is, are NPIs and provider specialty information available in CMS files?
Yeah, those are good questions. I will admit, it has been quite a while since I was in the row level data when I was working on the architecture. I believe the actual dates of service for the claims are available in N3C. But obviously we have several sites that date shift their EHR data. And so in those cases, obviously on date shifted sites, the dates would not necessarily match. But I think it's also relevant to point out that this is a little challenging, and it's something that I have worked with, and I don't know that I have a perfect solution to, which is the case that when a site brings in their EHR data, patients are matched and visits are not matched. And so you have patient A, and you know that they're at the same site. But when you have a visit in their claims and it doesn't match their EHR, you're not entirely sure, like, is that data that wasn't sent from the site, or is that potentially from a different site? I mean, there are kind of ways that you can get around that, or infer, like, is the associated data the same? Does it seem to be the same type of service with the same diagnoses and procedures? But that is sometimes, still challenging. It's not like validation is as simple as, we have visit 1, 2, 3, 4 in the EHR, and we have visit 1, 2, 3, 4 sitting in the claims, and they're linked with the same ID number.
Interesting. So the sites are anonymized, I guess, in both cases. Certainly with claims, I gather.
I think want to make sure I add something. So the dates are there. The data is linked. The patients are duplicated. We only feds can see the NPI and site ID. So if you're a fed, you're allowed to see that. If you're a clinician that's not a fed, you can't. But Locke's team did categorize providers and provider sites, and I can't remember the exact terms, but like for instance, I'm a psychiatrist, so you wouldn't say Dr. Gersing at Duke. It would say would say this person is an MD, and he is a psychiatrist, or they are a psychiatrist, or they are an anesthesiologist. They're clustered by profession, and sites were were changed to be type of site. And I'm going to get this wrong, but it's something like large, urban, academic, and things like that. So you wouldn't know it's Duke, but you would know it's a large academic site. In addition, I have a question and great talk, Peter. Thank you. I have a different, to me, that the optimal, we know that if you have both claims and EHR data, you have, depending on the type of thing, whether it's a procedure or a visit or a med, it's a different percentage, but it's quite a range of, it adds quite a bit. Like visits, it can add up to 50% more visits, and medications, it's something like 10% more. So my question, the idea always was that these two files would actually work together, because obviously claims data does not have values of labs or values of procedures, which is unfortunate. But as you were saying, EHR is incredibly messy, but at least it has labs. So I was just curious, as you how you experience the additive effect of the two, and what does it contribute to? And the other thing is that claims is well characterized, which is true, but it's recorded by coders. So having been in this world many, many years, a coder's job is to upcode as much as possible, though we don't use that term because it's illegal, but it's true. And so actually the information in CMS data, though well codified, is coder's version of a diagnosis of a visit. I was curious how those two things, if you had any feedback on those two things.
Yeah, I mean, to me, just the first piece, I guess also just a clarification for people that are coming from a claims background. So as Ken said, NPIs are not included. TINs are not included too. Oftentimes when we work with claims data, we're thinking about TINs from like a site perspective, but like NPIs, TINs are taken out of this data. Yeah, I mean, the additive piece, I think, is a huge component of this. And I mean, to me, I mean, different use cases, might have different perspectives on this, but to me, it's the multi-site that I view as the most valuable. It's the ability to, really get the 365-degree view of the data, and to get the additional procedures, diagnoses, and visits, meds from the multiple sites. I mean, I've looked a little bit at, to some degree, like validation of single site data. Does it seem like we're missing stuff from an EHR feed based on the claims data? And I think there's some level enhancement, but I think certainly to me, the biggest value proposition is the multi-site aspect. I don't know that I can sort of quantify more specifically for a specific use case or clinical scenario, because I feel like so much of my time has been spent kind of on the ingestion and operational side so far. But I mean, to me, it has to be the number one value proposition basically for looking at this data, is the fact that you are getting the view of the patient services outside of the single site. To your point, sometimes adding up to 50% addition beyond what you're getting from the EHR data.
So
I mean, go ahead.
Go ahead.
Okay. On the coding side, yeah. So, I mean, I think we would call this, I forget what the terminology would be now, reimbursement optimization probably. But and this is probably different places, but you are right. I mean, what comes out for claims is, I mean, it's a big game of telephone, right? There's what's actually happening with the patient. There's what the physician perceives. There's what they record. There's what the coder picks up. That is obviously spun towards optimizing reimbursement. But I mean, there are a lot of guardrails in place for that too, right? I mean, you might be doing some amount of rejiggering of ordering, on something like an inpatient visit, but there's kind of a limit to what you can do there. It's not like you could drastically rearrange an ordering of diagnosis codes or procedure codes to make or to re-represent the purpose of the visit. Well, I mean, I'm sure there places are, but that would be fraud, right?
One of the things that I think that we saw at Stony Brook, and we were looking at EHR versus coding actually to better understand our Vizient scores. So, and this is potentially relevant in terms of long COVID and other diseases where a patient is admitted for a different reason. And the question really, so the coders naturally focused on reimbursable sorts of things and secondarily focused on sort of more dramatic quality related things. But what we were looking for were things that were relevant to the patient, apparent in the EHR, apparent in the past medical history, likely still going on, and not necessarily coded. So is that something that you've given thought to or dealt with?
I'm not sure you're asking me or Ken.
Or any, but sure. I mean, because you've been thick into it, because we've talked about coders perhaps exaggerating or pushing to the maximum legal the reimbursable conditions, but I'm dealing actually now in some sense with the recall. So there's a positive predictive value aspect of coding, and there's the recall aspect that you don't necessarily get everything that's going on.
Yeah, I mean, for sure, right? I mean, even, take the UV04, right? Like there's kind of a limit to what you can load into that data pipeline. And even if that expands over time, typically there's kind of a reimbursement cap, right? And once you sort of code out a chart and hit the reimbursement cap, typically the coder stops coding regardless of whether there's more information or not. I mean, it's true. I mean, but I don't know. I think there's more nuance to it than this too, right? I have to think that what we're really largely talking about here is like facility or inpatient focused, compared to something like PV or outpatient, where the coding is just, I mean, to me, it seems like a much smaller dynamic because so much of the documentation is actually driven directly by the physician, right? You have a form, you put in HCPCS level 2, you put in a diagnosis to justify it. The coder might review it, but I mean, there's that game of telephone is potentially much shorter in some of these places. And then the piece that I would be interested in, but I don't know as much, is sort of how the prospective payment sort of weighs in on this, right? Like there's not as much prospective payment in outpatient and professional sides, but there is obviously on the inpatient side, and how much of an incentive does that potentially play on sort of the coding versus the documentation piece? I mean, I personally think that the characterizing the differences and sometimes the optimal use cases of claims or EHR is not a very well described area. So one of the things I've always been really interested in is something as simple as the Charlson Comorbidity Index. We've never really had a truly validated EHR-focused method to calculate that. It's always based off of administrative data. But in the EHR, obviously, we have even a lot more diagnostic inputs that you can use. Do you use what are essentially the claims diagnoses, the final build? Do you use the problem list? And I think it was just last year, there was a paper that was published really saying, like, you have pretty different results using problem lists or EHR diagnoses and claims diagnoses to calculate this thing. Like, we probably need some methods work. And so, I mean, I think these are good questions. I mean, I don't have amazing answers, but I think that they are really, I think they're important areas of academic research.
No, this is great. Well, wonderful talk. Thank you very much. And Ken, do you want to announce what you put in the chat? That's very, very important, the large CMS data.
Yeah, but first of all, Peter, I just want to thank you not only for the presentation, but all the work you've done on trying to make this better and usable. It's very, it's a lot of, nobody's ever done this before like we're doing it. So really, I can't thank you enough. Just real quick for the team, would be the CMS claims people don't have lab values. So the phenotype they use to identify matches always had to be just off of a diagnosis, right? And so we convinced, CMS was actually easy to convince, but that we could just match everybody in N3C. So because probably most of Americans now had COVID, so really the people in N3C that are not COVID lab test positive just never got it recorded. They're just, I think the better description might be COVID unknown or COVID likely because you're an American. So we're going to get matching off of all of N3C, but just like Peter said, it's still just the sites that are agreeing to link. And I do think we're up to 32 sites now that have agreed to link. So we have gotten more, but we're guesstimating, because we tested this, it'll roughly triple the numbers. So like Peter said, I think there's roughly 50, 60,000 Medicaid, that'll go to 180, something like that. And I think the Medicare will go to a little above 1 million, maybe 1.1, 1.2. So anyway, just coming soon to a theater near you. We think in January we'll have those new files.
Great. All right. Well, this was a great session, and have a
Thank you.
wonderful holiday season. And thanks again, Peter. Take care. Bye-bye.
Thanks. Bye.
Great talk.
you.
Thanks.